Good morning, everyone. I'm Dr. ANUSHA AJWANI, Vice Chairperson and Consultant at AJWANI Eye Hospital, Bhopal. And today I'll be speaking something about ICL in front of the big people. And I'll try to make it a little simple. So let's start with it. So phakic intraocular lenses, also known as implantable contact or Collamer lenses or implantable phakic contact lenses. These are lenses that are surgically inserted into the eye, where they provide excellent quality of vision with predictable and stable results. So it is a hydrophilic hybrid acrylic implant made of biocompatible collagen polymer known as Collamer, which does not cause reaction inside the eye and is positioned between the iris and natural lens. Coming to the advantages, firstly, it is far from the endothelium, causes lower induction of higher order aberrations, has superior contrast sensitivity. There is preservation of accommodation, which is a definite lead over RLE, provides excellent cosmesis and has retinal image magnification. Apart from that, it has a stable location, it is easily removable or exchangeable, there is no fixation into the tissues, and it does not alter the shape. Coming to the indications and prerequisites, the most common is patients who are not suitable for LASIK due to high powers or thin corneas, when the residual bed after LASIK is likely to be less than 250 microns, when the initial corneal thickness is less than 480 microns, and the patients should have an ACD more than 2.8 mm. They should have a stable refraction with no ocular pathology. Coming to contraindications, most common is corneal dystrophy or endothelial cell count less than 2000 cells per cubic millimeter and ACD less than 2.8 mm, and history of glaucoma, history of uveitis, and presence of anterior or posterior synechiae, and evidence of developing nuclear sclerosis. So the most commonly used are posterior chamber ICL called EvoVision ICL, marketed by Star Surgical. The spherical ICL used for correction of moderate to high myopia from -3 diopters to -20 diopters. Toric ICL can correct up to -3 diopter to -23 diopter sphere and 1 to 6 diopter cylinder as well. The toric ICL has the same overall design as the spherical ICL with the addition of a toric optic. Coming to the lens design, it has a posterior curve to vault over the natural lens. There's presence of a central hole which allows for natural aqueous flow from posterior chamber to anterior chamber and eliminates the need of preoperative iridotomies and almost no cataract. The perioptic holes help in discarding the viscoelastic. Coming to the workup, firstly we need to do a dilated refraction, white to white measurement for ICL sizing, ACD measurement. The implant size is selected on the basis of horizontal white to white and ACD, and we need to add 0.5 mm to horizontal white to white measurement for IPCL overall length. Apart from that, the other parameters include a refractive stability, pregnancy, and we need to check for the retinal status, dry eye status, axial length, endothelial cell count, keratometry, and angle measurements. For the instruments we need for white to white, a digital caliper. In this, it has proven to be a simple but reliable method, and we need to make sure that the caliper is well calibrated and take the measurement with patient in supine position. Apart from that, there is optical biometer, pentacam, and however vernier caliper is no more used. So there are variations in white to white. If the digital caliper gives a reading of 11.7, pentacam or OpsCan can give 11.9 and LensStar can give 12.3. We need to evaluate discrepancies between the measuring devices and between both the eyes, and both the eyes should have about the same white to white. Coming to sizing and vault, an ideal sized IPCL will provide a vault that is central distance between the anterior surface of the crystalline lens and posterior surface of IPCL within a range of 250 to 750 microns. An ideal would be 500 microns, that is equal to 1 corneal thickness. High vault, that is 1000 microns, can result in angle crowding and angle closure, glaucoma or pigment dispersion. A lower vault can result in contact with the crystalline lens and resulting in cataract formation. So the size of ICL varies with the white to white measurements. Like if the white to white is 10.75 to 11.14, the size of the ICL would be 12.1 and so on. And the white to white measurement must be horizontal 0 to 180 degree. Newer studies state that in sizing the ICL, a formula that includes a direct measurement of sulcus diameter by UVM provides vault height predictability and hence safety for ICL implantation compared with the current standard of using a white-to-white based sizing formula. Coming to the loading of IPCL, it has already been covered by him very well. So the only thing, improper loading can result in upside down implantation. So we just need to be a little careful. So the lenses of different brands have different designs. IPCL here has a special patent hole on the upper left corner to ensure the proper direction of the lens while loading into the cartridge and unfolding inside the eye. We need to observe the IPCL for proper orientation in the cartridge, and anterior side of the lens is facing upwards. These are the steps. We have already been through that. Procedure under topical anesthesia, 1 or 2 side ports and 2.8 to 3.2 mm clear corneal incision, viscoelastic. In this technique, I have injected that. He does it in hydro. So viscoelastic is injected on top of the ICL to give more room. We do not inject the IPCL completely until you visualize the landmarks, as you still have control as IPCL remains in the cartridge. IPCL has a tendency to flip because it is made up of a collapsible material. So just be a little gentle and slow with it. And the ICL foot plates are tucked behind the iris. To control the potential cyclotorsion in supine position, the 0-180 horizontal axis can be marked preoperatively and on the slit lamp and reconfirmed on OT table. And complete removal of viscoelastic is a must to prevent post-op IOP spike and make sure the foot plates are behind the iris. Meiotic agent can be injected or you can leave the pupil dilated, followed by hydration of the incision. What if the IPCL opens upside down? So we need to wait and then put visco on top, to each their own method. We can take it out, like sir said, that is better actually, rather than doing this. But in this, I've put visco on top of the lens and manipulate in the periphery. Do the distal haptics first while the pupil is maximally dilated and avoid going across the central lens.
Can you please go fast or sum up, because we have 3 presentations, sir.
Yes, sir. Last is this. Coming to the complications, there can be decentration, crystalline lens touch, resulting in anterior capsular cataract, pupillary block, raised IOP. It may get stuck while injecting or might tear off, requiring manipulation, endothelial touch, pigment dispersion, and rarely endophthalmitis. Thank you.